Clinical governance simply is a framework for improving quality. It's a framework for improving quality. But what is quality? Well, in my mind, quality is patient-centred, effective, safe care. Very simple, that's a definition that Lord Aradazi in the UK, who's a big guru on quality and safety, came up with several years ago. But we often get headlines like this in many different countries, and I just want to run through some of the examples from the UK and some of my personal examples of clinical governance. I guess in the UK there have been a couple of big cases, and the first I'll call to mind is a GP, Harold Shipman. Harold Shipman killed at least 15 people by injecting them with opiates. It's thought it might have been 200 to 300 people. But the investigations into that case led to a whole load of analysis about the need for organisational oversight of individuals rather than just the individuals themselves. And we also realised that how we managed controlled drugs was really quite lax. Go forward a few years and we now come to mid-staffs. This is about 2004, 2008. At the time I was a primary care trust, which is a sort of mini health authority chief exec, and I was also a practicing GP. Those were difficult times. We had lots of financial challenges, as well as the usual 3% efficiency a year. We had really challenging environment, quality and finance. Mid-staffs had had several investigations into it, all was okay, and then one final investigation. About 200 to 300 people died through negligence. And what that highlighted was that the culture of an organisation is really important. Those people weren't bad, they didn't get out of bed to do a bad job, but in that environment, what they had done was driven that organisation so that outcomes weren't measured and that individuals didn't speak up. Out of that came the birth of what we call the Care Quality Commission, which is the regulator in the UK. So those are big examples in the UK, but what about my personal examples? Well, I started off as a GP, and indeed I was a GP till 4 years ago, till I joined Bupa. And I wanted to make a difference. So I wanted a framework to improve the quality of care. And I was in a town with 3 other large practices, and we sat down and we listened to what our patients were saying. And they were deeply unhappy with mental health services. So we were pretty naive in those days. I hadn't been on a management course or anything. I was just a practicing GP. But we decided, let's get together and put these services out to tender. No one had done it before, but you could, so we did. And guess what? We got a different provider, and we got very different services. And that is the first lesson. Listen. Put the patient at the centre of all we do. Go on a few years, and in my part of the world we were called semi-rural, which is very different from semi-rural here. But we were some distance from a DGH, and we had a maternity unit. One day a lady came in, she was 40 weeks, 3rd pregnancy, she was induced and she ruptured the uterus and died. She had breached all the protocols that we had in place, but what we found out, we weren't measuring outcomes. Actually, the outcomes from that unit were not good, and we should have known that for some time. So, outcomes, critically important. Go on a few years, and I've now moved to Cambridgeshire, so I was still a GP, but I was now Chief Exec of NHS Cambridgeshire and Peterborough. And literally in my first week, I appeared in court. And I appeared in court for the case of Dr. Ubani, the German doctor. He had come over to the UK and had gone to Cornwall and passed the language test in Cornwall. Don't ask. He passed it in Cornwall. He then, one Friday, flew over to my patch to work for a locum agency. Dr. Ubani was basically a cosmetic doctor. Yes, he had the right credentials and he was a family doctor. So he flew over. He didn't have an induction, or he had minimal induction, and he didn't really know what was in his bag. So off he goes. One of the first patients, renal colic. Patient with renal colic says, I always have 100 milligrams. In Dr. Abani goes to the bag, fishes around and comes out with 100 milligrams of morphine. How the hell 100 milligrams of morphine was in that bag? The patient died. So I ended up, my first week, going to court. What that showed was the complexities, the inter-organisational complexities of clinical governance and making sure it works across boundaries. And my last personal example is in the dark days of MRSA and C. diff, which was almost like a plague in the UK. The levels of C. diff and MRSA were really high. And you would talk to clinicians and you would have the conversations along the lines of, well, we've got occupancy of 105%, it's really busy, it's a price you pay for a complex, busy health system. And I would have the conversation along the lines of, so how much infection is acceptable? And I ended up getting referred to the General Medical Council for bringing the profession to disrepute. But what we weren't doing was measuring stuff and making it visible. So I got out and I started looking at who was washing hands and who wasn't washing hands, how much deep cleaning was going on, how much isolation was going on. And over the country, when we started to do that, we actually found we weren't washing our hands as a profession. When we started to bring all those things together, we started to make it very visible, then the C. diff MRSA plague reduced significantly. So, a lot of lessons there for me, and so I ended up 4 years ago having run 5 primary care trusts, and as a GP, and then Bupa came along and said, would I like to be their chief medical officer? I had no idea what Bupa did, but it seemed like a good idea, and I joined, and I now have the best job in the world. So, what is Bupa? Well, we were formed in 1947 in the UK. 17 funds came together, and our purpose was prevent, relieve and cure sickness and ill health. And purpose is really important. You heard previously about purpose and culture, and I'll come back to that. So we've grown a bit since 1947. Our biggest business is Australia and New Zealand. That's about 45–46% of our business. Then Spain and the UK. We're also in Hong Kong, we're in Chile, we're in Thailand, Saudi, India, Poland, and I probably missed 1 or 2 out. What do we do? Well, largely, about 60–70% is funding. And then we also run hospitals and clinics. So in Spain, we run hospitals and clinics, some on behalf of the government. In Chile, we run hospitals and clinics, as we do in Poland and in Hong Kong. Then we have, I think, we are the biggest global dental provider in the world. Big chain in Australia, some here, UK, Spain, some in Chile, Hong Kong. And we also do other things such as GPs, and we run aged care facilities, which is what we do here and why I'm here. So it's a very complicated business with all sorts of differing governance issues. But this is probably the biggest driving factor for us, our purpose: longer, healthier, happier lives. And if you speak to anyone in Bupa, most of them know and own this purpose. And that's why a large number of people come to Bupa. And I guess when I joined it, actually as a GP and working in the PCT, that's why I used to get out of bed, to make a difference to people's lives, to improve the quality of their life, which is clinical governance, to help them do that. But then, in all my career, so as a GP and then as a manager or a leader, to start with, I used to think that the soft stuff wasn't really important. You know, it was all performance management, meetings, sorted out. That was important. But actually, the soft stuff is really important. And the culture of an organisation, as we saw in mid-stats, really dictates what happens. Now, if I look at this, for us, these are our values, and we are installing them in the organisation. Not everyone owns these values, but many do. And if I look at those, open, that's probably one of the most fundamental values for clinical governance. If the environment in Mid-Staffs had been open and had allowed people to bring forward their concerns, it wouldn't have happened. How do you create an environment of openness? The other thing in there, if we look at accountable. So, accountable is an individual's accountability. But often, what we do is we confuse accountability, or people feel accountability means I'll get the sack. So how do you support people to be accountable? And then I think authentic is a really tricky one. Particularly in appraisals and feedback, how do you give authentic feedback? Rather than just saying, yeah, it's all right, doing a good job. When in here you're having a different conversation. How do you have that supportive conversation? And it might seem a bit odd, we've got caring up there. What we're trying to do is in our recruitment processes, make sure that we do recruit caring individuals. Largely we do, but sometimes we don't get that right. What are the characteristics of caring individuals? And this is our journey in clinical governance terms. It's pretty recent actually, because Bupa was a financial services organisation, and our first clinical governance committee was in 2011. But if you think of the complexities of it, we have hospitals and clinics, which there was largely, the Spanish have a pretty good infrastructure, and actually, if you want to see good, really good clinical governance, go to Poland. They have a superb clinical governance infrastructure. But what did clinical governance mean for aged care? What did it mean for dental? What did it mean for, we run the immigration visa service for the whole of Australia. What does it mean for that? And so our journey really was initially getting the clinical governance meetings in place, then starting to look at quality, and then starting to look at risk. And I would say we're now at a point, and clinical governance is a journey, we're now at a point where we're looking at continual quality improvement. We've still got a lot of work to do, but we're well down that journey. And this is really, just don't spend too much time reading this, but these are the sort of boxes of clinical governance that we look at. And if I've talked about the softer stuff, but structure is important, particularly when you have an organisation like mine that covers many different aspects and many different parts of the world. We're broken up into 5 market units. So this part of the world will be a market unit, and there will be a team in Australia who will oversee the clinical governance of New Zealand and Australia. And then that feeds into us in London. I sit on a clinical governance committee, and then I go to the risk committee in London. But it took a long time to get that structure right, to get the flow of information right. You heard about capabilities before, and that's really, really key. And if I look at our care home business in the UK, we have something like 300 care homes in the UK. I told you the regulator had changed and became the CQC, the Care Quality Commission. And they have become really fierce. So overnight, we went from most of our homes being good to most requiring improvement. And we've seen the same in the hospital sector as well. And so we have to work out how we structure ourselves to really improve the quality of the care homes. And what we've done is basically systemize, you know what I mean, how you run the care home. So there's 50 different processes, and you measure those processes, and that resides with the responsibility of the care home manager. But then we have a support quality team which helps with that process. So being very clear on who does what role. Staff are absolutely crucial, and there's a whole different elements on staff, from making sure you have the right staff in place. So locums, for instance, in the UK, in our care homes, were really quite high, and we've had a big push to bring down the use of locums. but then really supporting staff so that they all have, you know, a meaningful appraisal, meaningful development. But you need to go just that little bit further. Because what we want to do is instill a culture of continual quality improvement. So if there's something you need, it's curiosity. Just curiosity about wanting to improve the quality of care. And as Buddhists say, it's having a beginner's mind, not coming with pre-existing views, but just having a beginner's mind. And then finally, risk. I'll talk a little more about our journey on risk, which has been really extensive, but you need to understand the risk of your business. And then you need to say, so what are the tolerances for risk? What are we going to accept? What are we not going to accept? So this is the structure. I mentioned it before. It's quite complicated. 5 different geographical units, and under those sit, so here in Australia and New Zealand will sit the visa medical services, the care homes in New Zealand, the insurance business, primary care, and our other businesses. That will then feed through to my committee, which then feeds through to the risk committee and the board. And what's interesting is that when I joined Bupa in 2012, within 6 months, I was the top risk of Bupa. So that was a really great start, wasn't it? I was now numero uno in risk terms. I'm glad to say that now, 3 years on, I think I've fallen off the top highlights. I'm about 8th or 9th, because we have a process in place to manage that risk. Right. One of the things we are very passionate about in Bupa is what we call the 3 lines of defence. So that's making sure who does what. And the 3 lines of defence would be, so take our care homes business here. They're the first line of defence. We'd expect them to have processes, policies, undertaking audits to make sure that what they do is of high quality. And there is a whole process in our care homes here, and they record data and they challenge that data. Then, in Australia, we have a central team at the market unit who challenge, assure, advise and support. So they look at that data, they make decisions on it, they work out how they can help. And in different parts of the world, those needs are different. I sit above the market unit at the centre, but I'm still second line, because I need a third line. I need an external audit who comes in and sees that what I'm doing is right and the right thing to do. Otherwise, I could well be blind to the organisation. And so we have this in all aspects of risk, in financial and in non-financial. And it takes a long time to get in place, but it really does put in place the checks and balances. So a little bit about our priorities. And one of the Global Quality Review Programme, so we look at the information coming in from the risks, from critical incidents, and then we decide what do we need to work on. And a couple of things we're working on at the moment are endoscopy across the world and maternity across the world. Previously we looked at pressure ulcers and falls. So we decide, and then we say, right, who's got good practice in endoscopy? Let's get the different people together, let's share that, and then let's see how we can improve our endoscopy service. So, global quality review. Clinical effectiveness, I have a small team at the centre that looks at the clinical effectiveness of drugs, devices, interventions. And a couple of those we've gone to town on, like hepatitis C. In our business in the Middle East, that is absolutely huge and really complicated, and we've simplified that with various algorithms. So hepatitis C, and interestingly, end of life is another one, because end of life care is absolutely crucial to our business, and to get that right. And so learning from good practice around the world. So end of life for us was important. Partnering with customers is a really important issue. So I said, put the patient at the centre of all you do. We've got a pilot on, it's called shared decision making. Some of you will have heard of it. And it's about ensuring that the clinician and the patient jointly reach a decision on what's right for that patient, rather than doctor saying, you need that, off you go. And what we do, we've got a pilot in Chile, Poland, Hong Kong, and it's in collaboration with Dartmouth in the US, and we measure when the patients come out whether or not their needs were met. It's a simple tool, and we are finding that when we start to use these techniques, we get very high patient satisfaction rates. So, shared decision making is crucial for us. I'll talk a little more about professional development later. Risk management. So I said what we do is we identify risks in the different businesses, and then we bring those together. So the sort of things we'll measure would be critical incidents. Critical incidents, they're graded 1 to 5, 4 and 5 are severe incidents. So severe critical incidents, and one's in the same category. Then we'd look at how quickly were they investigated, root cause analysis. Who's working to our standards? Are you working to our standards? Are you not? And we have a range of 4 or 5. And then what we do is we set a tolerance for each of those. So we have an appetite within which we'll accept risk. So you can imagine it gets a bit complicated because we've got that for dentistry, we've got that for primary care, we've got that for care homes, and it all comes together at the centre to give us a risk appetite. But understanding your risk is absolutely crucial. You can't read that, but it's basically my work plan. So I sit at the centre of what am I focused on this year and next year. And for me, the evolution of clinical governance, we have in place the structures, the processes. We're measuring some important indicators. But as I said, I now want to go to a continual quality improvement approach. I'm also very keen to get in place global standards. And this is something that we always have a debate about. You know, should the standard be the same for a Bupa customer anywhere in the world? Well, yes, if it's infection control. You know, there are some things that we should always have the same standards on. So I'm working on standards. Another one is outcomes. And this is a really difficult one because it's very variable. So in the UK, we invented patient-reported outcome measures, which is basically, say someone has a knee replacement. You ask them about their function before, and then their function afterwards, and then you can correlate who improved and who didn't. And so we are collecting a mixture of outcome measures. But the challenge here is to collect just a few so that you get a view. In my NHS days, I remember in the heydays, I think, I was responsible for 250 different performance measures. And it was rather difficult to remember them all. And, you know, if you measure all those many things, you won't keep your eye on them. So what are the few things you're going to measure? And two other things that we're doing. Went to Chile. We're building a new hospital in Chile, 450 beds, Clínica Santiago. Doctors said to me, what does Bupa offer us? And that was what I now call my Chile moment. What does Bupa offer doctors in Santiago? So what we've done is form a clinical academic partnership. We went through a process of putting out a spec for a third party to support our clinicians. And by clinicians, I don't just mean doctors, I mean nurses, I mean dentists. And we now are working with Dartmouth University in the US to look at how we can support our clinicians and how we can spread best practice. And within that, we have Jan Adams, who is leading our care home business here, who some of you will know, who is also our global nurse and developing a global nursing strategy. So what do we measure? Well, this is largely what we measure. And we've been around the houses on this, but it's not easy because everyone measures it differently and it takes time to get it right. The big debate we have at the moment is third-party providers. So what can we expect of them? And we're probably going to add 30-day readmission. We have a big debate about mortality, and I went through that in the UK big time when we had different measures of mortality. And you know, one of the challenges with data is you have to know what it means. And if you collect data and you don't know what it means, it's really challenging. So that's what we measure, and we've been measuring that for some time. And when there's an issue, we then go back to the market unit and say, so what do you think of this? And they may say there's a reason, or they may say we don't understand it, and then we'd look in more detail. But let me just talk about measurements, because measurements are crucial. And I'm a big believer in simple run charts. You don't need a PhD in statistics to do this, okay? So, go in a care home and you plot how many people are falling on a simple run chart. But then what you do is you put upper and lower control limits in. And it's pretty simple, you can Google it, and you have an upper and a lower control limit. What that does is that tells you if your system is in control. So if you're going along like this, but you're within those control limits, that's normal variation. When it spikes out, that's abnormal variation. And far too often, what I see is, you know, 2 data points, and all hell breaks loose. We must do something about this. It's a terrible thing. It's changing. Actually, it's normal variation, and it's 2 data points. So understanding data and plotting data simply is absolutely crucial to clinical governance. So the key issues for us, well, there's no rocket science here, and just a few things about this. Medication errors is on the chart, and that's something actually that New Zealand's leading on. We work with a community geriatrician out of Auckland who's been supporting us for some time, and has now, with his help, we've now got electronic medication process in our homes, and we're rolling it out. And the ones we've put it in, it's rapidly reduced medication errors. So medication errors, you know, is a really good story for us, as are falls and pressure ulcers. And we measure these across the world. And it's interesting, the cultural differences. So go to Spain, and when I first joined, I went to Spain, and there was all this thing about preventing falls, and in Spain, the relatives think it's important to keep people restrained so they won't have a fall. And that's normal. And you go along to a home in Spain and you say, well, actually, we want people to be mobile, you know, want to get up. And they say, well, they might have a fall. So the cultural thing about restraints is really difficult. And in Spain now, we lead the way in restraint-free homes. And it's just crept into the culture that this is a really good thing to do. So culture in different parts of the world is different. Now, emerging risk, antibiotics. So what could we do about antibiotics? Well, one of the other things I do is I run a Chief Medical Officers network. I thought it was quite a lonely place being a Chief Medical Officer, and so I put an advert and found a few more. And we now have 46 Chief Medical Officers, from IBM to Intel to Qantas, Emirates, Goldman Sachs. So all over the world we have 46 of us. And some of them are in banking, some are in mining, some are in healthcare. And what we do is get together to talk about what can we collectively do to improve the health of our workforce and communities. And we're just about to go and meet in America to look at what we can do on antibiotic resistance. And it's a tangential approach, but it's taking quality improvement out into the wider world. Right, so the key challenges, and I would say the key challenge is clinical engagement. Clinical engagement is always challenging, but when done well, yields great results. And clinical engagement has to happen on the ground. What I learned from my time in, the NHS was to get effective change, it needs to come from the bottom up. People need to understand that they want to make that change. And one of the most challenging places for me was Cambridge in the UK. Highly academic. So I was hardly going to win an argument with oncologists about the cost of drugs. Cambridge was bust. We were already paying back 25 million a year for a dispute we'd lost several years ago. And so I wanted to look at how we could more effectively manage oncology. And then along came a paper from the New England Journal of Medicine. What that paper showed, and I think it was for lung cancer, was that actually good palliative care is, first of all, more cost effective, but you know what? You lived longer. That was a surprise. You lived longer with good palliative care rather than having third or fourth chemotherapy drugs. And so I spent a lot of time sitting down with doctors, and I learned that sitting in an office telling people to do something, it won't work. And it doesn't work. Me sitting in Holborn saying to, New Zealand or Chile, I want you to buck up your thinking on falls. You have to get those people wanting to do it. Other challenges as well. So I've talked a bit about the contextual stuff about, so this was we came up with an risk appetite statement. All clinical work had to happen in regulated entities. Until we realised in India there aren't any. So that was problematic. So how do you get over that? And those are the sorts of challenges we face with different parts of the world. The likes of Australia and the UK and Spain are one thing, but in some parts of the world it's not so regulated. But even the UK, Spain and Australia, I'm a big believer in understanding some basic measures from the providers we have. There's a lot of regulation in those countries, but we as the purchasers of care need to understand that they really are making and meeting the standards we expect for our customers and our patients. And then, finally, this is really important for me, health and safety. And it's the health and safety of our staff. So I guess that's you guys, clinicians and nurses. And we often overlook this. So if I look around our business, we have significant numbers of slips, trips and falls, manual handling, injuries in care homes. Often thought that it's a price you pay for the job. But it's not, is it? We came up with a strategy, and the second bit of our strategy was about putting our employees at the centre of all we do, supporting them so that they can do a great job. And actually, I hit on something here, because what I did was I said, I don't understand why all this is happening. So I asked Dartmouth to do a literature search on why would staff have slip, trips and falls and manual handling. And it was pretty clear on manual handling. What it threw out was culture. The culture of organisations and the way those organisations operate directly can affect slips, trips and falls and manual handling. And then I hit on another idea. Years ago I was in part of the NHS called the Modernisation Agency, where we looked at how we could improve care. And so I've set up what I call 90-day challenges, plan, do, study, act. So we've got some care homes in the UK and we've got some care homes here. What we do is we say to the staff, so you're having falls, you're having manual handling injuries. What do you think the cause is? What could we do to make that right? And then they say, well, if we change this, then let's do that and let's just measure. So on a simple run chart, they measure it. A few weeks later, they look at that, they say it didn't work, or did work. And then after several of those iterations, the plan, do, study, act, we then take that and start to scale it across the business. So I think what I'm trying to say there is the crucial nature of getting front line to understand the challenges. So I'm just going to end on a note now because, so in my journey throughout healthcare, for me, clinical governance is all about improving quality. That's what I was a doctor for, that's what I went into it for. I realised that I could do that in my consultation room, but also stepping outside of it, I could also do it. But that isn't just a bureaucrat's job. It wasn't just my job as a CEO. It's every single member of this room. Because effectively, you're the people who will make a difference. You know the challenges to your patients. So in summary, I would say the soft stuff is really important. Really, really important. Culture and purpose of an organisation. You do need structure, and the bigger the organisation, so when you get to my sort of organisation with 80,000 staff, 34 million customers, you've got to have structure. But it's trying to get that structure right. And at times we've got that wrong, and it's been bureaucratic, and then we pare it back. You've got to have structure. The next thing is measurement. Measurement's really important. Ask yourself, is what you're measuring the right thing? And do you understand it? Do you still need to measure it? And then finally, folks, it is all our job. And there is no other job, no better job than improving the quality of care for your patients, my residents. So, ladies and gentlemen, I think I've left 5 minutes between now and coffee. So, Andrew, I don't know if you want to take general questions or...